now gives me tremendous pleasure, I had to say that because she's my boss, to introduce Dr. Cynthia Kaplan, who's a wonderful friend, working together with her for a very long time, and is going to talk about treating trauma and borderline personality disorder, because it is one of the most difficult challenges in treatment, together with some of the people who have talked about substance abuse and eating disorders, but this will focus on PTSD. Dr. Kaplan.
So, what I'm going to talk about today, as Blaise said, is, let me get this through, is how? Okay. Okay, let's start there. That doesn't come up. Okay. So the co-occurrence of borderline personality and trauma presents many challenges for assessment and treatment. I think if you heard in Mary Zanarini's presentation, there's always been a high rate of co-occurrence found between trauma in a BPD population, and the rates that are found have varied, but they are often as high as 50%. I know in the study Mary just presented using adolescent BPD patients, she found a lower rate of trauma in that population, but it still was very significant, around 20%. All the epidemiological research that's been done has pretty much indicated here abroad, it's been done in a variety of places, that there's a 25 to 30% overlap, that if somebody has BPD, there's a 20-30% chance they may have post-traumatic stress disorder, and vice versa. So it becomes a major issue that you have to contend with. Also, BPD clients are found to experience adult traumas at a very high rate, sometimes as high as 90%. And co-occurring PTSD, if untreated with BPD, has a worse prognosis in terms of the overall likelihood of long-term remittance of BPD. And clients that have both diagnoses engage in higher levels of non-suicidal self-injury and other problematic behaviors. So it is a major co-diagnosis that has to be dealt with. But it has presented a dilemma not only for adults with BPD, but particularly for the adolescent population. And what's been the problem? The problem has really been the rate of suicidal ideation, suicidal behaviors, non-suicidal self-injury, dissociation, and substance abuse that exists in populations that have either PTSD or BPD, even if they don't co-occur. When they co-occur, all those problematic behaviors occur at a higher rate. So these are just some of the statistics from the larger studies that have shown that, again, people with PTSD 6 times more likely to engage in suicidal behaviors and 5 times more likely to report SI. And relative to other diagnoses, you can see how high they fall. That was in the large European study. And 50% to 60% of adolescents and adults that are treatment-seeking PTSD report that they have histories of NSSI. Now what happens, slides are not very good, I hope they're better on there, but suicide and self-injury in clients with BPD, many of them, 70%, have reported multiple episodes of NSSI. They engage in more NSSI when they have comorbid PTSD. And as we all know, the rate of completed suicide has been reported very high in BPD. And clients that have both of these diagnoses report also very specific trauma-related cues for self-injury. So when you deal with people that have both diagnoses, they will often say that one of the triggers or prompts for them hurting themselves is that they're having some thought or they see something that's a reminder of the trauma that happened to them. So a lot of the NSSI that we see and substance abuse and dissociation is actually mediated by trauma-related cues. So it presents a real dilemma, and we try to take a look at the claim in our adolescent services to see what we would find in terms of the percentages and the prevalence of these problems. In the literature, among hospitalized adolescents, it's reported to be as high as 93% that you have a co-occurrence of at least one trauma in treatment-seeking populations, whether they have BPD or not. We looked at sequential admissions in our own ART, the McLean programs, and we found a rate of 73.5% of the adolescents reported at least one index trauma, and they often felt it did contribute to their criteria for coming into the program. 50% of those met a formal diagnosis for PTSD. So it ran at about 30%, and that's very consistent with, again, what the larger studies find, 25 to 30% of formal PTSD in treatment-seeking populations and co-occurrent BPD. And once established, PTSD can be very tenacious and debilitating. And it can also, PTSD leads to a lot of other problems in adolescence and can be associated with significant increases in other high-risk behaviors. So that was the next thing. We took a look at just to try and get an idea of how important is it to try to come up with a protocol to treat adolescents that have BPD and PTSD. And these are the results from 254 sequential admissions on our ART, and you can see that, interestingly enough, and some of this may also be explanatory for some of what Mary found, that our rate of sexual violence, childhood sexual abuse, is actually very similar to what she found, but rates of things like school violence have gone up tremendously. Alex was talking about the school programs, but so the pattern of traumas that kids report have shifted over the last 10 or 15 years, but they still, again, 73% reported at least one index trauma, and many kids, I don't have the statistics in front of me, actually had 2 or 3 more different categories of traumas on their way in. The one we know the most about is childhood sexual abuse, which is such a strong predictor for adolescents of substance abuse, chronic disorder, and depression, and also a huge trigger for suicidality during adolescence. And they also, adolescents that have childhood sexual abuse, but some of this goes for other categories of abuse as well. They have many more high-risk behaviors. Teens, sexual abuse corresponding to high-risk sexual behaviors, but other kinds of abuse related to substance abusing and all kinds of other conduct disorder, depression, high-risk behaviors. And they're more likely to report health problems starting as teenagers, and as Mary described, often that follows them into adulthood. So we next took a look at risky behaviors, and again, I'm not sure if this came up better on but what we found was that for childhood sexual abuse in most categories, kids with a history of childhood sexual abuse engage in significantly more risky behaviors, and kids with trauma history came next, and kids with no trauma engaged in the lowest number of risky behaviors across these 4 categories. So again, it shows why, although it can be very difficult and challenging to treat PTSD, particularly comorbid BPD, when you try to leave post-traumatic stress disorder alone, it doesn't work very well either. So that's been the approach for some period of time, which is worry about further destabilizing kids, which I'll go into. But it looks now that the perils and costs of leaving it alone are much greater than those of treating it, because of the collateral damage the kids do and how many other risky behaviors and self-destructive behaviors they end up engaging in if they have untreated PTSD. Here, for example, on our substance abuse unit, just another example of what happens. Well, alcohol and marijuana, which we tend to think of, not that anything's a normotypical drug, but drugs that may not get kids into huge problems early in their life, don't show great history, difference between maltreatment and no maltreatment. When you get into populations where there is childhood maltreatment or abuse or not, we start to see a huge difference in amphetamines, cocaine, inhalants, LSD, and all the drugs that would then later either form an independent substance abuse problem and lead to other problems around aggression, sexual promiscuity, and a lot of re-victimization happens to kids that have childhood PTSD, if it's not treated, they get these kind of secondary traumatizations, or again, a lot of the adult traumatizations that Mary found in her longitudinal research, up to a rate of 90%. It also impacts the kind of partners they pick, et cetera, et cetera. So what is the treatment dilemma? The treatment dilemma really is that you have two different diagnoses, and people have been loathed for really the last almost 2 decades to directly treat the PTSD. And have been trying to outweigh it in some ways, modulate it, see if that's something that can be treated later on in life. And that is a very complicated history, but the truth is we had very good treatment for PTSD, very good, a lot of randomized controlled trials, very effective, which are the cognitive behavioral treatments. The one with the most empirical support includes prolonged exposure, but most of them have components in which there is a part of it where you recreate the trauma narrative, and where you do in vivo experiments by approaching things that you've learned to avoid as a consequence of the trauma, trauma reminders, and then eventually some sort of trauma narrative or reworking of the trauma with the therapist. To do that, obviously, you are going to re-evoke memories and thoughts and feelings of that experience. And what happened sort of, and it's interesting because Marcia, as early as '93, referred to exposure in her work as something that was very important, but it never, till much more recently now, has become, starting to be formalized in terms of how to integrate that with the skills-based DBT approach. And a lot of that was because of the pendulum in our country and elsewhere, where PTSD got into the DSM. It was done completely on adult field trials. It really wasn't defined for what PTSD looks like in kids and adolescents. The ideas became new and horrifying as kids came forward to talk more openly in the 90s about things that had happened to them. And then there was the backlash of the false memory foundation, implanted memories, all the notions that therapists were starting to act as forensic personnel, untrained to do so, what's uncovered, what's not, and whether you should be trying to uncover things or not. And it sort of became a little bit of a melee where people would rush in very early, there was not a lot of empirical support, to try to do exposure. They weren't even calling exposure, they were just saying, we're going to talk about the trauma. And there wasn't a lot of attention paid to what the ramifications were with legal and social service, with parents and families who often didn't know anything was going on or disagreed with the version of what was going on, with therapists leading clients. There's now a lot of evidence to show that you can have young kids say things happened to them that didn't, et cetera, et cetera. And also some bad outcomes with urges becoming behaviors, people re-engaging, being triggered by the trauma memories in self-destructive behaviors. And the hugest problems actually drop out from treatment, which became about 40%. So we didn't yet have a really good cognitive behavioral therapy, so people were approximating them in their own practices with this exposure. Didn't go very well. So the backlash to that really became all these rule-outs for doing focused PTSD treatment, and the rule-outs are many of the criterion behaviors for BPD. So what happened is we have two co-occurring diagnoses, and they both need to be treated, but if you have certain criterion behaviors, you weren't for a long time considered acceptable to have PTSD treatment. So those rule-outs included, as you can see, SI-NSSI, substance abuse, severe dissociation. And the current practice guidelines written by Foa et al. As of 2009 say significant suicidality is present, et cetera, it must be addressed. So many, if not most, BPD clients and many adolescent BPD clients were excluded from PTSD treatment, and so it left unanswered the question of what were we going to do, because anybody that's worked with adolescent BPD clients who have PTSD, they will repeatedly say, I need to talk about what happened, I want to talk about what happened, you won't let me talk about what happened. You're saying I shouldn't be as avoidant, but every time I try to be less avoidant, you tell me that it's not time to talk about this yet. I don't want any details, I don't want to hear about it. Clinicians became very fearful also of being told things and then not knowing exactly how to deal with all the filing and legal and family fallout from these things. But then the attention luckily was turned back to DBT. I mean, many of us who do a lot of trauma work continue to do what's called informal exposure. So it's not that people completely stopped talking to kids about trauma, but we did it in a very slow-moving way, and a lot of us adopted the guidelines of getting rid completely somehow of self-injury and suicidal ideation and substance abuse, and you'd be in this merry-go-round, sort of, where you'd be waiting for that year mark to come, or some period of long-term stability, and you felt good that the kids were learning skills, and a lot of these behaviors were decreasing, but as they went out and tried to generalize what they've learned from DBT, they often would be triggered. As they left a more secure environment, the PTSD symptoms would be triggered again, and those would often trigger a target one behavior, or at least increases in urges, or a little bit of pot smoking or something, and all of a sudden the treatment would be put on hold, or people would have seen it as having started too soon. So people tried just doing DBT to see if we could get rid of the PTSD that way, and those research studies have been very clear. DBT does almost nothing for PTSD. You get rates from 13%, the highest in one of Melanie's recent studies was 30%, but it's not anywhere near as close to the remission rates and the improvement you get when you use standard CBT approaches for prolonged exposure. So it's essentially like, you have two different disease entities, two different problems, and we were hoping that by treating the BPD, it might go over and help the PTSD, but in fact that doesn't happen. And it even looks like if it's left alone, the risky behaviors, etc., come around and trigger some of the target behaviors again that have been stabilized. So again, this is just the current exclusion criteria for prolonged exposure right now. And if you look at these, you can imagine what it's like trying to get adolescents to meet these criteria. So where do we go from here? What we're working on now, and this is largely being done by the people with behavioral tech, but these are the approaches that we're using in the claim, is that we're trying to use DBT as a primer treatment to stabilize the suicidal behaviors, the substance abuse behaviors, the self-harming behaviors, and get people stable enough to be able to begin the prolonged exposure work. But what is really new is that rather than a year out, which used to be the guideline until very recently, DBT is being used as a first approach for 8 weeks now, with the idea that if stabilization can happen for 8 weeks on the self-harming behaviors, that actually starting exposure work and work on the trauma in a very graduated way could actually help continue skill build, continue people to have an integrated sense of identity, to be less anxious, and to feel like they are efficacious in their own treatment and in getting their PTSD symptoms under control. So this is one of the studies that Melanie and Marsha are currently working on, and when they had BPD and PTSD clients, they showed significant decrease in severe dissociation and substance dependence, as well as the targeted safe self-harm behaviors over a year, and by 8 weeks of time, many of these patients, which these are still adults, would have met criteria of having these behaviors under control enough to start doing some prolonged exposure. So in terms of the child world, CBT with prolonged exposure is the treatment of choice when you just look at single diagnoses, kids with PTSD. There's now a whole bunch of people that are developing these hybrid models, which use some skills-based followed by an exposure-based approach to treatment, so to not wait and either hope the PTSD goes away or treat it too soon before you have a firm skills base that the child client is able to use to keep some of their more unsafe behaviors under control. And there's emerging evidence that this PTSD treatment also needs to be comprehensive for kids and adolescents. Again, a lot of what Jill and Alec were talking about, and has to include family, school, and relevant agency involvement. Can't get through it. So here's the new empirically supported CBT features for children and adolescents. This is taken from a lot of different people's approaches, but Coleman, and Devlinger came up with these guidelines. And I think they'll seem quite obvious, but it is the new way people are looking at to integrate the treatment for PTSD and BPD. And you've got to have psychoeducation, we've talked a lot about. There have to be skills that are focused on emotional regulation. There have to be cognitive coping skills. There is a place for the trauma narrative and cognitive processing of that. So you can't really walk around that into your PTSD. You have to have a place where those trauma triggers and memories and foci are directly approached. In vivo desensitizations into some of the trauma cue seems very important. And the big one down at the bottom, conjoint child-parent sessions and a consolidation of the work at the end of the work to enhance safety and future development. So I'm running out of time, but it's just really to capture this. It's become a staged intervention now. So there's a pre-treatment assessment, and that looks at the level of all of these safety behaviors, what supports there are in the environment, how we can bring skills on board during the early stage, where safety, education, skill building, and the development of the treatment alliance. But then the mid-stage that's put in here now is a trauma processing and resolution. So that mid-stage, which used to be where treaters launched as a first stage with people that were traumatized, has now been embedded after a long period of, not long, 8 weeks of learning skills and trying to figure out what the hierarchy of traumas in their own life, how they're going to rate those, and how they're going to work out an exposure plan with the therapist, and then an end stage of self and relational development. And just only a few words about this. It's very important to do a comprehensive initial assessment. That's what was missing, I think, in the initial attempts to treat this. I think you have to ask if there's a history of trauma and then know what it was, how severe, how frequent. You have to decide whether the patient meets the criteria for formal PTSD, although a lot of people, a lot of Marcia and Melanie stuff now is working on non-criterion index traumas. You don't have to necessarily formal PTSD. What's the index trauma that the patient wants to work at? What are they being bothered by? Not necessarily what you think is the problem or their family thinks is the problem. You have to evaluate dissociation and try to help them work on that with skills, because that will interfere with the PE sessions. You've got to evaluate the extent of the substance abuse. Again, prolonged exposure is being done now with substance abusers, asking them not to smoke 2 hours after the session or take other substances which may decay the value of the emotional processing. Figure out whether there's complex PTSD too much to go into now, but then refer for forensic evaluation if suspicion of unconfirmed trauma persists. And that may be the most important one for people that want to learn how to do that, because it goes back to what we learned the hard way, which clinicians never ought to imply that any symptomatology is the consequence of a forgotten or denied trauma in the absence of a direct confirmation by a child or caregiver. So we're not supposed to do Columbo. It doesn't work. We often give people a false sense of what happened to them, and there can be many negative sequelae. And then the last is the important parental involvement. Sometimes people think of trauma as very personal, particularly if it's sexual in nature. And when you try to do this work and you don't involve the family, it never goes as well. So on 3 East, we always have initial meetings with families and kids separately and then together, which is something that FOA and others recommend anyhow. The families receive a lot of education about PTSD and what prolonged exposure and CBT are, how it fits in with the DBT skills, We do a lot of work on confidentiality and privacy and helping them understand that you don't need to know the details of your kid's trauma. You just need to know that something happened and this is how we're working on it with them, and have some assurances about their safety from whoever that person was and in an ongoing way in the environment. And again, it's transactional. Parents can find more when they get some information about this, and they get actually less intrusive, which is what the kids are always worried about, that they're going to somehow hand over control. And family meetings are critical to developing contract around homework, caregiver roles and crisis management, homework hierarchies. And then the last thing, which is we're finding a lot on 3 East, which is the importance of joint exposure and skill development. I don't have a statistic in front of me, but a high number of our families have had a joint family trauma that has probably become a vulnerability factor for what may have later happened to their adolescent, or is the actual trauma. So we've had, boat accidents, deaths of siblings, all kinds of things that have happened, fires that burn down houses, etc., where they come in, and the first presentation is the kid has PTSD, but when you really work with the family, you realize that the whole family system's been traumatized, and that, or even drinking in a parent, there's lots of scenarios in which a kid's been traumatized by something, and it does directly involve their family. And we've had a lot of success, clinical success, working with families and kids together on family exposure. So that's the newest thing we've sort of been looking at. Okay? Thank you.